Hello everyone. I welcome you all to the series of lectures in respiratory medicine. Today we will be discussing yet another important topic, which is bronchiectasis. So let's start off. So what is the meaning of this bronchiectasis, right? So if you break down this word bronchiectasis, bronchi plus ectasia, bronchi plus ectasia. So bronchiectasis means dilatation. Bronchi is your bronchi, ectasia means dilatation. So bronchiectasis means dilatation of your bronchi. So there is an abnormal and irreversible dilatation of your bronchi, predominantly your medium-sized bronchi with fibrosis. So how is bronchiectasis different from emphysema? Where emphysema also you can have dilatation, but that is involving your small airways or your small bronchi. Here in bronchiectasis you have abnormal and irreversible dilatation of the medium-sized bronchi and consecutively leading to fibrosis, right? So this is bronchiectasis. Fine. Also there can be increased mucus production. There can be increased mucus production, right? There can be increased mucus production, and this leads to an obstruction within the bronchi. This leads to an obstruction within the bronchi. Okay. So finally it results in what type of disease? It results in an obstructive lung disease. It results in an obstructive lung disease. What are the other obstructive lung diseases that we know? The other obstructive lung disease includes your chronic obstructive pulmonary diseases, including your chronic bronchitis and emphysema, right? So this is your other obstructive lung disease that you know apart from bronchiectasis. Okay. So bronchiectasis basically refers to the abnormal and irreversible dilatation of the bronchi, predominantly involving the medium-sized bronchi. So let us look at the etiology of bronchiectasis. Etiology of bronchiectasis can be infectious as well as non-infectious causes. So when it comes to the etiology of bronchiectasis, we have infectious as well as non-infectious causes. When the infections, most often it is bacteria. What are the bacteria? They are usually the fastidious organisms like Pseudomonas, right? They are fastidious organisms like Pseudomonas, and there can be rarer organisms like Burkholderia, right? So these are some of the bacteria which can be associated with bronchiectasis. Then non-tuberculous mycobacteria. Then structural causes. So whenever there is a damage to the structure of the bronchus, there is loss of the elasticity of the bronchus, there is loss of the compliance of the bronchus. This can result in super added infections. So these type of bronchi cannot clear out the secretions well, right? Because there is damage to the cilia, there is damage to the structure of the bronchus, they can have super added infection. So where do you find that? In your post-TB sequelae. We know that in your post-TB sequelae, you can have predominantly upper lobe cavitatory lesions, destruction of the bronchi, and hence you can have post-infectious bronchiectasis in these conditions as well. In conditions like lung sequestration, this is a congenital condition where parts of the lungs are sequestered, and this can have superadded infections. Okay. So if there is a structural damage to the bronchi, you can have bronchiectasis. Then we look at non-infectious causes for bronchiectasis. So what are the non-infectious causes for bronchiectasis? Immunocompromised individuals in itself have a difficulty in clearing out the mucus, so they are prone to bronchiectasis. Then genetic conditions. What are the genetic conditions that predispose to bronchiectasis? We have cystic fibrosis. Cystic fibrosis is basically a disorder which is inherited in an autosomal recessive fashion. So this is due to mutation in the CFTR, which is cystic fibrosis transmembrane receptor, which is basically involved in your chloride ion transport, and chloride ion concentration of a particular secretion is influenced by the CFTR. So in cystic fibrosis, this is damaged, as a result of which you have thick tenacious secretions which accumulate within the lung and can cause bronchiectasis. Then Cartagener's syndrome. What is Cartagener's syndrome? It is characterized by sinusitis, bronchiectasis, and situs inversus. Sinusitis, bronchiectasis, and situs inversus. So this is basically a ciliary dyskinesia. This is basically a ciliary dyskinesia. What is the meaning of ciliary dyskinesia? Cilia are the ones which basically help in removing out the secretions. So if there is a ciliary dyskinesia, there is a problem with the motility of the cilia. The secretions get inspissated and it cannot be coughed out, and it results in dilatation of the bronchi. Then we have alpha-1 antitrypsin deficiency and Young's syndrome. Young's syndrome is also a ciliary dyskinesia. Apart from bronchiectasis, you can have azoospermia. You can have azoospermia and infertility. So these are the genetic conditions. Then developmental disorders. There can be developmental disorders where the bronchi and cartilages of the bronchi are not well developed. So this is seen in your Monier-Kuhn syndrome and Williams-Campbell syndrome. Williams-Campbell syndrome, there is absence of tracheal cartilage itself, and hence the bronchi are not that strong and you can have dilatations. Okay. Then autoimmune disorders like RA and Sjogren's can predispose to bronchiectasis, and the presence of tumors or foreign bodies. How does this cause bronchiectasis? Till now, whatever we had discussed usually causes a generalized bronchiectasis. Bronchiectasis can involve more than one region, but the presence of tumor or foreign body is depicted here in this diagram. So if there is a tumor or foreign body, this tumor or foreign body can basically cause effect from outside the bronchus. It can compress on the bronchus, right? So if it compresses on the bronchus, for example, in this tumor, then you can have dilatation of the bronchi. Or in the presence of a foreign body within the bronchus itself, the air which is coming in can come in easily, but it cannot be expelled out, and hence it causes dilatation and the bronchi lose their elasticity. So this type of bronchiectasis due to a compression or because of a foreign body results in a focal bronchiectasis. Okay, so this results in a focal bronchiectasis. Okay, clear? So this is about the various etiologies of bronchiectasis. So you can have infectious, non-infectious causes, genetic causes, developmental disorders, autoimmune, immunosuppressed individuals, and focal bronchiectasis in case of tumors and foreign bodies, right? So this is about your etiologies. Now, based on the location, which part of the lungs are affected, bronchiectasis can be classified as upper lobe predominant, middle lobe predominant, or lower lobe predominant. So based on the location, bronchiectasis can be classified as upper lobe predominant, middle lobe predominant, or lower lobe predominant. Upper lobe predominant bronchiectasis is seen in cystic fibrosis, ABPA sarcoidosis. Okay, cystic fibrosis, ABPA sarcoidosis. Middle lobe bronchiectasis is seen in non-tubercular mycobacterial infections, and this is also called as Lady Windermere syndrome. Okay, this is also called as Lady Windermere syndrome. So what is this? This was actually, Lady Windermere was a character in one of the old novels where she used to suppress the cough, right? So in NTM, this name has arisen because of that character who used to suppress the cough and hence develop bronchiectasis. So here you have middle lobe bronchiectasis secondary to non-tuberculous mycobacteria. Primary ciliary dyskinesias like Pathogenesis syndrome also affects the middle lobe. Lower lobe bronchiectasis is seen in ILDs, aspiration pneumonia, hypogammaglobulinemia. Okay. In ILD, the type of bronchiectasis that you have is very, very different from the other types. So if this is your bronchi, in interstitial lung disease, you basically have scarring. You basically have scarring and fibrosis of the parenchyma. So they are going to pull the bronchi away, and it results in something called as traction bronchiectasis. Right? So traction bronchiectasis is seen in ILD. Okay? Traction bronchiectasis is seen in ILD. Okay? Fine. So this is your traction bronchiectasis. Now what is Brock's syndrome? In tuberculous lymph nodes. Tuberculous lymph nodes can cause compression. It can cause compression on the middle lobe, and resulting in a bronchiectasis which is called as Brock's syndrome. So middle lobe bronchiectasis is called as Brock's syndrome, right? So this is very, very clear based on the location. What are the examples? This is little memory based. Please try and remember at least 2 to 3 examples under each. Okay. Now let us understand the pathogenesis. Let us understand the pathogenesis of bronchiectasis. So the pathogenesis is given by this hypothesis which is called as vicious cycle hypothesis. The pathogenesis is given by something called as vicious cycle hypothesis. So the first trigger is usually due to an infection, for example, tuberculosis, pseudomonas, mycoplasma infections. These infections result in inflammation of the bronchi, right? And there is loss of smooth muscles, right? So initially there is only inflammation, later on there is loss of smooth muscles, and there can be irreversible damage by destruction of your bronchial cartilages. There can be destruction of your bronchial cartilages, resulting in an irreversible damage to the bronchi. Now, if there is irreversible damage to the bronchi, then what happens to the walls, right? So, the walls of the bronchi become weak. There is a loss of cilia. The cilia which are here are becoming dysfunctional. Then you can have goblet cell hyperplasia. You can have goblet cell hyperplasia, right? And what happens to the secretions? The secretions are going to get accumulated here. The secretions are going to get accumulated here. And there is mucus hypersecretion as well. There is mucus hypersecretion as well, right? So, initially there is inflammation, but repeated episodes of inflammation is going to cause loss of smooth muscle, damage to the cartilage, going to cause bronchiectasis, and there is weakening of the wall, goblet cell hyperplasia, and mucus hypersecretion. The cilia which are responsible for ensuring that the secretions are secreted out is not going to function, and hence they get accumulated like this. So finally the bronchi become dilated, becomes bronchiectasis. Also, this is finally going to result in inflammation again, and this is your vicious cycle, right? So the mucus is not going to come out, again there is going to be bronchiectasis, again mucus is not going to come out. So this is going to be a vicious cycle, right? So this is your vicious cycle hypothesis for the pathogenesis of bronchiectasis. Okay, now let us understand on pathology what are the types of bronchiectasis that you can get. So the most common type is a cylindrical dilatation of the bronchi called cylindrical bronchiectasis. Then you can have a snake-like dilatation called varicose, and then you can have cystic dilatations called cystic bronchiectasis. Right, so can you see on the pathological specimen? So this is your normal undilated bronchi. Here can you see that the bronchi are cylindrical. Here you can see some varicosities. These are cystic dilatation of the bronchi. Okay. On histology, you will find destruction of the cartilage, mucus gland hyperplasia, and a lot of inflammatory cells within your bronchi. Okay, so you can have destruction of the cartilage, mucus gland hyperplasia, and lot of inflammation. Let us look at the clinical features one by one. Okay. So first and the most importantly, any patient with bronchiectasis is going to present with cough. And what sort of a cough will he have? He will have a suppurative cough. Okay, he will have a suppurative cough, and there is production of copious amounts of sputum. There is production of copious amounts of sputum. Copious amounts of thick sputum can be produced in a patient with bronchiectasis. Another important general physical examination finding is the presence of clubbing. On auscultation, what are you going to find? On auscultation, you are going to find coarse and inspiratory crackles. You are going to find coarse and inspiratory crackles or crepitations, mainly because of the inspissated mucus and secretions which are going to flood your lung. You are going to find coarse and inspiratory crackles. Right? Apart from this, you can have hemoptysis, right? So there can be erosion of the bronchial vessels. You can have hemoptysis. If the bronchial wall breaks, there can be erosion of the bronchial vessels. You can have hemoptysis. What is bronchiectasis sicca? Usually, bronchiectasis is associated with production of large amounts of thick, tenacious, copious sputum, right? But in certain conditions, there can be no sputum and you still have bronchiectasis. So this is what we call as bronchiectasis sicca, right? So this is about the various clinical features. Patients with bronchiectasis, unless there is an acute exacerbation or an acute severe infection, they usually do not have fever. They usually do not have fever. Okay. Though they might have malaise, they might have some generalized systemic symptoms, malaise, weight loss because of chronic underlying infection, but they do not present with fever. Okay. Clear. Now, let us look at the diagnosis. So how do you diagnose it? What do you see on the X-ray? On the X-ray, you are going to find dilated bronchi, but it is not quite visible on the X-ray. The best investigation of choice would be a CT chest, right? So on the CT chest, what will you find? So the first sign that you find on the CT chest is called as a tram tracking, where you have thickened valves. Okay, so here you have thickening of the valves, and these basically go parallel to one another. The bronchial valves are parallel to one another and they go around without tapering up to the end of the lung. Okay, so can you see here that this is your thickened valves and dilated bronchi which do not taper up to the terminal portion of the bronchus, right? So there is no tapering, non-tapering of your bronchi. This is called as your tram tracking. Then second, you can have signet ring sign. You can have signet ring sign. Can you see these dilated bronchi? These dilated bronchi have an airway diameter more than 1.5 times the corresponding vessel. So if this is the airway, this is a vessel, the bronchi are dilated more than 1.5 times as compared to the vessel, and this is called as a signet sign. There is lack of bronchial tapering that we already saw, and the last appearance is called as a tree in a bud appearance. So tree in bud appearance is the third form of appearance that you can see. Okay, so these are about the various radiological signs that you can see in bronchiectasis, tram tracking, signet ring sign, lack of bronchial tapering, tree in bud appearance. Okay, fine. Now what are the complications of bronchiectasis? 1. Any chronic lung disease, even a bronchiectasis, can result in pulmonary hypertension, and this pulmonary hypertension can result in cor pulmonale. What is the meaning of cor pulmonale? It is right heart failure secondary to your lung disease. Secondary to your lung disease is your cor pulmonale. So how is this going to present? What are the clinical features? It is going to present with a loud pulmonary component of the second heart sound with a narrow split. Loud pulmonary component of the second heart sound with a narrow split. Apart from that, you can have a pansystolic murmur at the tricuspid region because of your tricuspid regurgitation. You can have elevated JVP. You can have A waves which are prominent, and later stages you can have giant V waves, right? Apart from that, if the right heart failure and the cor pulmonale worsens, you can have abdominal distension because of ascites, tender hepatomegaly, and pedal edema. So these are all the characteristic features of cor pulmonale. These are all the characteristic features of cor pulmonale, right? And in the later stages, you can have hypoxia and hypercapnia as well. Second complication is hemoptysis, right? You can have streaky hemoptysis, you can have massive hemoptysis. Management will vary. Any chronic disease can result in secondary amyloidosis. It can result in secondary amyloidosis, and hence you will have proteinuria. Apart from that, the presence of this mucus within the bronchial cavity can result in predisposition to recurrent infections and recurrent pneumonias, right? So this is about the various complications of bronchiectasis. Now, finally, let us understand what is the treatment. Let us understand what is the treatment of bronchiectasis. So, treatment of bronchiectasis predominantly involves the use of antibiotics, right? It use of antibiotics. So, if they have frequent bacterial infections, especially the bacteria are usually Burkholderia pseudomonas, so you use beta-lactam antibiotics. You use beta-lactam antibiotics, and if it is an NTM infection, you treat them with long-term macrolide therapy. Now, apart from your antibiotics, you have to maintain your bronchial hygiene. So, you give bronchodilators. Because bronchiectasis ultimately is an obstructive lung disease. So, you have to relieve the airway obstruction by giving chronic bronchodilators, and you have to thin out the sputum. The sputum becomes very thick. So, that has to be thinned out by giving 3% NaCl or N-acetylcysteine. This is N-acetylcysteine. Okay. DNase or antidornase is basically an enzyme which helps in breaking down your thick secretions, and this has been approved only for the treatment of bronchiectasis in cystic fibrosis. Then anti-inflammatory therapy can be given, but the main part of your management of bronchiectasis is your rehabilitation and prevention, right? So once a patient has been diagnosed with bronchiectasis, you have to prevent your further episodes. So you have to do a pulmonary rehabilitation. So you do pulmonary physiotherapy where they come and teach the attender how you have to do a chest physiotherapy and mobilize the sputum and cough it out, right? So that is your pulmonary rehabilitation. So in your chest physiotherapy, they teach you breathing techniques. So they teach you deep breathing techniques. Apart from that, they also teach you different types of chest physiotherapy where you stimulate the chest wall and you breathe along with that so that you expel out the mucus, and this ensures that there is no accumulation of mucus within your bronchial tree. Okay, fine. You also have devices which are worn. The devices, for example, you have a chest device. So this device is basically a vibratory device. It produces vibration to your chest wall, and this vibration is going to move out the mucus and helps you cough it out. So these are new devices available for the treatment of bronchiectasis. Prevention. Preventive therapy is required when the number of acute exacerbations are more than 3 per year, and we give vaccines in your prevention therapy. So for what are the vaccines that they should be having? They should be getting pneumococcal vaccines. They should be getting your annual influenza vaccines. So pneumococcal and annual influenza vaccines are required to prevent your recurrent infections. Suppurative antibiotics have also been found to have a role, especially your inhaled colistin. Oral, especially Ziplocs, can be given for up to 2 weeks every month in cyclic. And macrolides can be given up to thrice a week. So the main problem with a suppurative antibiotic therapy is that there is a high risk of resistance. Hence, only the patients who are deemed for therapy should be given suppurative antibiotics. Right? So with this, we have come to our end of our discussion on bronchiectasis. Thank you.